panel discussion on extensive disease small cell lung cancer. And to moderate this session, I would invite Dr. Deepak Mulajker from Delhi Army Hospital RNR to moderate the session on this panel discussion of small cell lung cancer. Dr. Deepak, please.
Thank you so much, sir. It's always a pleasure to see you and listen to you, sir. So I'll be sharing my screen, and so the topic is kind of optimal management of extensive stage SCLC. The topic has been titled by the organizers, and I'm presenting our own case from our own center. I don't know whether we have actually done an optimal management or not, but let's see what the panel thinks of it. With this, I would like to invite all my panelists on board. And to begin off, this is our patient. He's a 48-year-old gentleman. He came to us in April 2020 with dry cough, dyspnea on exertion, no other comorbidities, otherwise fit individual. He was evaluated at a peripheral center. The chest X-ray showed some mediastinal widening, and without losing any further time, the patient was transferred to us. We did a bronchoscopy. We found a extrinsic compression of the left upper lobe bronchus. There was some mucosal infiltration in the bronchus intermedius. We went ahead with a biopsy. The biopsy came as small cell carcinoma lung, and a PET showed that there was a large 7.6 centimeter mass which was encasing the right main bronchus. It had lymphangitis carcinomatosis in the lower lobe, and there were multiple skeletal lesions, bone marrow deposits. MRI brain was normal. So here we come to Dr. Vikas. Are you there? So how would you further manage this case? Okay, Dr. Kaushik.
Okay. Sir, as per the details available, sir, it's an extensive stage small cell lung cancer. I hope his PS is good, sir.
The PS is 1.
PS is 1, sir, and the MRI brain is normal, sir. So based on the present available evidence, sir, he would be a candidate for chemoimmunotherapy, sir. The combination of immunotherapy plus EP combination, sir.
Okay. So Dr. Deepan, what do you feel? That chemoimmunotherapy is the way to go forward, or you would still feel that probably only chemotherapy would help?
Only chemotherapy would help, sir, but based on the available data of chemoimmunotherapy or chemotherapy, EP only, it has a OS benefit. So given no other constraint, especially economical constraint, I would like to go for a chemoimmunotherapy, as you have mentioned, sir. PS is 1. Hope adequately, no cytopenias provided already a bone marrow medicine.
Okay. So, Dr. Dubey, I think in your talk you made it quite clear that you are going for chemoimmunotherapy itself, and that would be your first choice of treatment, would it?
Yes, sir. This systemic chemoimmunotherapy will be my first choice of treatment owing to the details and the data available. But if this patient is quite symptomatic, patient is very much dyspneic and not able to maintain saturation and all, then, sir, I would like to individualize the treatment for this patient. I would like to go ahead with palliative RT first. Then I'll go with the systemic chemotherapy, at least if depending upon the symptoms what patient has.
Okay, fine. Colonel Abhishek is around. Patak?
So Colonel Abhishek is not there, sir. Sorry.
Okay, fine. So more or less the panel seems to think that probably chemoimmunotherapy is there. And like we all know that looking at the mutational burdens, we don't have any targetable lesions. It's a disease which is characterized by mutations in the tumor suppressor genes. You can look at TP53 and RB1, nearly 100% involvement. There's transcriptional addiction and there is epigenetic dysregulation. But other than that, we don't have any targetable lesions, unlike in NSCLC. So pros and cons, probably everybody is now for chemoimmunotherapy. But Anvesh, what do you think? What chemotherapy would you use upfront? Yeah, Anvesh around? Okay, Kaushik, what chemotherapy would you go with?
Sir, if only for chemotherapy, sir,
No,
we
it's
have
not only chemotherapy. Even when you are giving chemoimmunotherapy, what chemoimmunotherapy would be the preference for you?
sir, with chemoimmunotherapy combination, if I'm using Atazo, the data we have with only with the carboplatin and etoposide, sir. If it is with the Durva, then we have data both with the cisplatin or carboplatin with etoposide, sir.
So platinum plus etoposide.
Platinum plus etoposide.
Is Dr. Swami around? Okay, Dr. Deepan, so do you think in the chemotherapy, if you were giving any other agents, this has been mentioned in the talk earlier also, but do you think any other agents would are better than EP as a backbone?
Sir, previously it was though the earlier also mentioned. I would like to give etoposide and platinum based chemotherapy. Though old cycloadria and I think CAV vincristine based regimen also was in history part was more toxic without lots of side effects compared to etosis with no added advantage. Well, another regimen as a historical point of view can be there, but I would go for the Ito and platinum base with immunotherapy.
Okay. So Dr. Dubey spoke about this trial which was done in Japan and JCOG trial that he spoke about. And here they said kind of irinotecan cisplatin was better than cis-etoposide. Dr. Dubey, you kind of glossed over saying that it is the pharmacogenomics, but all other trials was in the Western population. So
Yes, sir.
is there anything that which says that this may not work as the first line in Indian population?
Sir, that is the point, sir. I concur with your point. But the thing is that this is the only trial which has shown that irinotecan plus platinum is superior to etoposide plus platinum. Otherwise, there are at least 3 studies which have shown that there is no improvement in replacing etoposide by irinotecan. So I'll be quite skeptical using irinotecan until unless I have like a dire need of using only this drug, and there'll be something like I'm not able to use etoposide. Otherwise, etopo plus platinum will be my first choice of treatment.
So fair enough, but I just wanted to bring this because this will become clearer as we proceed into the case. So again, this has been kind of brought out by everybody that probably people have tried PEM carbo, they have tried ACE, they have tried CEV, CAV, and more or less platinum plus etoposide seems to be doing better than the other alternatives except for that JCOG trial. So how many cycles, Kaushik, do you think you're going to give? 4, 6, what's the data is already mentioned? Dubey.
The data we have with the 4 cycles of combination with immunotherapy, followed by immunotherapy maintenance.
Now, this is a gentleman who's around 45 years of age, is otherwise fit. And the thing about it is, do you still restrict yourself to just about 4 cycles of chemotherapy, or would you think of 6 cycles here?
So after the 4 cycle, we can get the assessment done, sir.
Okay.
If it responded very well, sir, then we can withhold the chemotherapy and continue with the immunotherapy.
Oh.
If the partial response, we can go ahead with the improvement with the 2 more cycles and then reassess. And,
is Dr. Suman around?
Yes, I'm here.
Dr. Suman, what is your view on this 4 versus 6? What do you do in your practice? I mean, let's forget the data from the trials and everything. What do you do? As we are all consultants here, and what do you do in your practice?
Generally, the reassessment is done after the end of 4 cycles of chemotherapy. And then if the response is really good, we may drop the last 2 cycles. But in a young patient, we generally go on to do all the 6 cycles of chemotherapy.
So in a younger patient who's probably tolerating the chemotherapy, has had a good response, you would go up to 6 cycles. Is that it?
Yes, that is.
So Dr. Dubey, your practice, please.
Sir, I will individualize the treatment that how much response the patient has shown. Like if the patient has shown extra thoracic response is very good, only there's a residual disease, the only thoracic residual disease, then I'll go for thoracic irradiation rather than like continuing the chemotherapy. If the disease is both extrathoracic and intrathoracic, then because the patient is young, then I'll continue with 2 more cycles of chemotherapy if provided patient is responding in some other way.
So in your practice, generally what do you do? Is 4 or 6?
Sir, 4, sir.
4. Okay, fine. So there are 4 and 6. So again, this is a NCC and doesn't help us there much. Says 4 cycles are recommended, may receive up to 6 cycles based on response and tolerability. So I think it depends from, as Dr. Dubey has already brought out, from you individualize the treatment. But like Dr. Suman has said, that probably a fit patient who's tolerating it, good response, probably would like to consolidate with 2 more cycles. Okay, now we come to the question of which IO. So Kaushik.
Sorry, sir, Dr. Shivshankar is here, sir, now.
Okay, Dr. Shivshankar, you can take this. Which IO do you prefer when you want to give it? Whether it is Atizo, Durva, what is your take on this?
Sir, in terms of benefit, both Durva and Atezolizumab both have almost a similar clinical magnitude of benefit. But thing with Durvalumab, probably the trial setting in which they have conducted, it is much more wider. They have allowed a option of both carboplatin or cisplatin based therapy.
Yeah.
Whereas with Atezolizumab only, it is carboplatin based therapy.
Okay.
And second thing is even brain, those who have a asymptomatic brain metastasis, they were also allowed with Durvalumab. Whereas with Atezolizumab, those who had a asymptomatic brain metastasis was not allowed in the upfront setting. Those who have only, been treated brain metastasis, they were allowed. Whereas asymptomatic brain metastasis was not allowed. Other than these 2 differences, I do not see much of a difference whether we go for either Atezolizumab or Durvalumab.
No, the question is not that. The question is, what do you go for?
I have used Durvalumab, so I'll go for Durvalumab.
Okay, so okay, Dr. Dubey, you, what about you? Which one is your choice? Well, like he's already.
I've used around in 9 patients. I have used Atezolizumab, sir. So okay. I would surely would like to use Durva also in few patients, but I have used Atezolizumab and I have much more hands-on experience with Atezolizumab. But I concur with the points what Shivshankar said. There were only mild differences that yes, asymptomatic brain mets were not included. Otherwise, platinum-wise, there was already meta-analysis that cisplatin and carboplatin are having similar efficacy. So any of the drug can be taken, sir, depending upon the availability and whatever the patient can afford.
What about Pembro, Nivo, EP? EP and Nivo or Pembro? Like this slide.
Pembro actually,
both the trials did not get a OS benefit.
Yeah, numerically there was trend towards OS, but clinically, statistically significant it was not. Pembro.
Okay. So we are now down to Durva and Atezolizumab. So like this has already been brought out very nicely that probably PCI was kind of, these differences have already been said, so I'll not waste my time here. And Caspian versus IM power 133. So this is a very nice slide, and it tells us that probably in real life, we probably treat more patients on the line of Caspian rather than on IM power 133. So anyways, but both of them more or less are, I would say, equivalent as of today. So now if you look at these graphs, now you have a down, and after a while, then they stabilize. So we are quite sure that, not all patients benefit from IOs. So Kaushik, do you think we have a way to find out whether we can select patients who can, benefit from IOs?
Presently, with the data available, there is no much of predictive benefit of either PD-L1 or tumor mutation burden. Only I consider the fit benefit patients for the PS1, they may benefit more.
Dr. Deepan, your views?
Same as Dr. Kaushik, sir. So there is no predictive thing as long as I know, by which we can predict that this IO will be beneficial for in selecting the patients in which.
And Dr. Suman?
I think insurance setting. I think your insurance should guide what treatment IO you will choose. Otherwise, the toxicity profile, safety profile, everything is the same. Efficacy almost is the same.
Okay, so as of today, probably this, if we even look at the subgroups, probably this is from IM Power trial, where they looked at whether there was a tumor mutational burden or whether there was, PDL1 was not kind of this thing, but then there was no difference. But there is this paper that was published last year in Cancer Cell, and it kind of made it into 3 classes of small cell lung carcinoma. So either it was neurorod1 driven, or POW2F3 driven, or ASCL1 driven. And there was that 4th category, which was more or less a triple negative kind of which was negative for either neurorod POW2F3 or ASCL1 driven, and it is called the inflammatory. Now, when we look at this, that there can be a kind of a class switching that can occur. As a patient is exposed to chemotherapy, there is a switch in the class, and then you might get a inflammatory kind of tumor. Now, if you look at the response to the immunotherapy that is there, it is this triple negative or SCLC inflammatory type, which has the maximum benefit. So I don't know whether this will come into clinical practice or not, but there is something on the horizon that is coming, and probably better characterization might help us to actually choose the patients who will benefit from IOs. The toxicity was, yes, was not much that great with addition of IOs, but financial toxicity remains. So probably in future, we might be able to select our patients and only patients who are going to benefit from IOs. But this is still published last year. Probably it will take time to come into the clinical practice, but there is something on the horizon that is always there. So going back to our case, the patient received 4 cycles of Atezo plus EP, and PET scan showed decrease in size and metabolic activity from about 7 centimeters. It came down to 2.3 centimeters. The metastatic lymph nodes, skeletal regions, nodules, and hepatic lesions had all regressed. So we said this was a partial response. So Dr. Shivshankar, what do you think we would do right now after this kind of a response?
Sir, in Atezo EP trial, only 4 cycles of chemotherapy was allowed.
Okay.
So after that, patient will be put on just atezolizumab maintenance. If he is a candidate for frequent MRI follow-up, as suggested in the Japanese trial, he does not require any PCI.
Okay.
If he does not agree for a frequent MRI follow-up, then probably if he is affording atezolizumab, I don't think that he will not agree for frequent MRI follow-ups.
Okay.
So just maintenance atezolizumab.
Okay, so one thing that I forgot to mention, that this gentleman was a doctor himself, and he was very concerned about his what do you say, the
Cognitive decline
about the so he of course did not agree for PCI. But what about thoracic RT?
Sir, thoracic RT only if there is a thoracic left out there. In that meta-analysis, they had shown that only those who have a residual disease in the thoracic and extrathoracic have almost cleared. Only in them there is a benefit of adding a thoracic consolidation. Not in all the cases.
Not in all the cases, but this is what had happened in this case. More or less, we had left with that 2 centimeter mass, a few nodes somewhere, and most majority of rest had all regressed more or less.
If all had regressed, then probably we can add a thoracic consolidations.
Okay, so Dr. Suman, what is your take on the role of radiation for this patient right now?
Right now, probably I wouldn't look at the role of thoracic radiation. I would rather continue atezolizumab as a maintenance.
So,
this patient.
So of course the PCI was mediastinal this thing. This was a study for PCI which actually showed that there was a OS benefit. Of course, there was another study which was published later on, and in which they excluded, they only did it in patients who did not have a MRI, any lesions on the MRI, and in that study there was no benefit of PCI. So in a patient who's with asymptomatic brain mets or no brain mets, probably we can withhold the PCI. And coming to the mediastinal RT, this is a trial which was again published in the Lancet. You can see there is a trend which favors a thoracic radiotherapy. So probably on this basis, we decided to go ahead with the thoracic RT, and we gave 4 more cycles of maintenance atezolizumab, 3 months MRI brain in view of young age, and we did not offer any PCI to this patient. It was a time of corona. Later on, patient had some corona related illnesses. Treatment was interrupted for a few times. 10 months later, he develops brain lesions. He's still asymptomatic for it. There's an increase in the metabolic activity of pre-existing right hilar lesion. However, the rest of the lesions are more or less stable. So, Dr. Kaushik, what would you do now?
For brain lesions being asymptomatic, we can keep him in observation, sir.
Okay.
Considering him is asymptomatic, we can have a MRI surveillance, and once he's symptomatic, we can go with the WBR.
Okay. And Dr. Dubey, what do you feel? What should we be doing
now? Like, I guess patient is off chemotherapy since I think more than a year.
Around about 10 months. 10 months.
Sir, before that, patient got only maintenance atezolizumab for 4 cycles. So I would like to re-challenge the patient with same platinum plus etoposide.
Okay, so we did the re-challenge is what we are. So we gave him 7 cycles of EP. He had a progressive disease, 7.1 into 7 centimeters now mass, which has increased in size. Brain lesions thankfully remained the same. He still remained asymptomatic as regards the brain was concerned. So Dr. Shiv Shankar, what do you feel? What should we be offering him right now?
Sir, yes, TFI of 10 months, right, sir?
10 months. We are after that we have again re-challenged, given him 7 cycles of EP. Mid-cycle evaluations about 3-4 cycles later, he was okay. It was a partial response, stable disease kind of a question. So we went on till about 7 cycles of EP. So now that the disease has progressed after re-challenge of 7 cycles of EP.
So he has a progressive disease while on EP. So in that case, I will go for irinotecan, single agent chemotherapy irinotecan.
Single agent irinotecan. Okay, Dr. Suman, what do you feel that you would be going for?
I would agree with Dr. Shiv Shankar, probably a single agent irinotecan, or sometimes even a single agent docetaxel as well.
Okay. Dr. Deepan?
Yes, sir. That compensation, the sir has mentioned irinotecan, but I would go for topotecan based on the CNS lesion is also there, sir, though it is asymptomatic, sir. So somewhat different.
Anyways, statistically, there's hardly any difference between all of them. So yes, we gave about topotecan for 2 months. MRI was scheduled at that time. The brain mets had increased in size. We evaluated for the rest of the body. It had more or less the stable disease, except for the brain mets increased. Patient still remains asymptomatic. There are about 2 lesions that were there. The subcortical lesions, no edema, and here we are. So Dr. Shiv Shankar, your thoughts on this?
Sorry, sir, just I had a call from hospital.
Okay, so I'll take to Dr. Dubey.
Now, if the patient is having otherwise extracranial disease is controlled, then I'll continue with the topotecan and will give cranial irradiation, sir. Whole brain RT.
Whole brain RT. Kaushik, what do you think you are going to do right now?
Sir, same, sir. Can have a talk to the patient, sir. Since it is asymptomatic at present, we can keep in observation and continue topotecan, sir.
Okay. So, well, there is nothing to guide us here, but then we decided to start with durvalumab, irinotecan, and carboplatin. So he received about 6 cycles. Post 3 cycles, there was very good response. We were quite surprised ourselves. But post 6 cycles, we had a new brain lesion, and he had one epileptic, one seizure activity. So the rest was stable. this time we spoke to him and he agreed for a whole brain RT, and we gave him a whole brain RT. Now that at this stage, and he's just finished his whole brain RT about a week back. Now we are at here, what should we be doing next? Dr. Deepan, what's your thought process on this?
Brain lesion progression, but that systemic, sir? Sorry, sir.
Systemic is stable.
Okay, so this is a tricky, sir, because in this patient, nothing further, which whatever we do, there will be a limited data. So I would suggest whatever the benefited most, either single agent immuno plus or single agent chemotherapy, identical some kind of maintenance, or immunotherapy already received sir, maintenance. So whatever the lung trial in what PDL1 inhibitor or PD1 that one inhibitor, the maintenance would be not feasible. So single agent IRINO will be a maintenance kind of a thing, sir. One thing I am thinking, sir.
Okay, Dr. Dubey.
Sir, I'll get patient has progressed on atezolizumab. I'll get foundation test done, sir, that to look for any targetable mutation. And till then, whatever chemotherapy patient is responding, I'll continue, because whatever you do right now, sir, it will be right, sir. It will not be wrong.
Okay, Dr. Shivshankar, what are your thought process? Patient has progressed post EP, post IRINO carbo. He's received atezo, then now he's also received durvalumab, and we are now at this stage. What do you think that we should be doing?
Sir, I mean, since even after first line of immunotherapy, for after a forced maintenance cycle, almost for 10 months, he did not have a progression in system in the extracranial sites. So I think he is kind of looks to me like a immune responsive disease. I'll put him on maintenance durvalumab in this case.
Okay, so maintenance durvalumab is what that. Let us say that this patient, we haven't as yet taken a decision what we are going to do with him, and we need to discuss it with him. But any other new therapies that in SCLC that you are looking at?
What is that?
Lurbinectedin. What about that?
Sir, I'll keep that on systemic progression for that option.
Okay, and Dr. Dubey, your thought process on that?
Sir, I have no hands-on experience with that drug. Maybe if anything which is available, then surely I'll use it, sir. If I'll be able to get it for patient, then for sure, sir. Because otherwise, I don't have any other options.
Okay, so the first one is this. So we had this patients, about 105 patients. They were between chemotherapy free interval less than 90 days and chemotherapy free interval more than 90 days. So the overall response rate was 35%, and median duration of response was 5.3 months. So this is another drug that we are looking at. And like I said initially also, that this is a tumor which is very high in mutations in the tumor suppressor genes and transcriptional addictions and epigenetic dysregulation. So this is one of the drugs which actually inhibits active transcription, and it binds to guanines in GC-rich areas of gene promoters. So this is one of the options that that we can look at. Any role you think of any temozolomide kind of drugs, or maybe PARP inhibitors might be having a role? Dr. Kaushik?
Sir, regarding the temozolomide, there are few data available with the temozolomide, sir, and the second or third line settings. Also with the taxanes also, sir. They are not exposed him to taxanes, so that can be tried, sir. Temozolomide, gemcitabine. Okay.
So, Dr. Suman, your thought process is that probably what about trying other chemotherapies? Let us say temozolomide or anything on that options.
I have not really tried, but like the previous speaker said, there is some sort of data for it. CDK4 inhibitors, you said, I think there is some data that is coming up for using CDK4/6 inhibitors as well, but I don't have any experience, so I
none of us have. We have reached a place where we have gone beyond the guidelines, and everything we do as somebody has already mentioned, is right. So PARP inhibitors, now this was another trial which looked at it, where they used olaparib with temozolomide. Both were dosed 1 to 7 days of a 21-day cycle. It has a very good ORR, so probably, and a median OS in a 50 patients of 8.5 months. So something maybe we can look forward to. And other than that, I think we can look at the other single agent, probably paclitaxel hasn't been used, temozolomide hasn't been used. There are phase 2 trials for lubrinectedin plus irinotecan coming up. So there are much on the horizon. And if you all remember, we got this patient in April 2020, and now we are sitting here all in August 2022. So let us see what we can offer him further. But the changing scenarios in the treatment of extended stage lung cancer, I think we should not be giving up, and how we are going to use the new upcoming agents will probably determine how much benefit we can provide to the patients. With this, I have come to an end of my talk, and I would like to thank the organizers for giving me this opportunity to present this. Thank you so much.
Sir, I would like to add one thing, sir, because this is important for this patient. Where any patient who is progressing on like drugs which are provided by Roche, like atezolizumab or Kadcyla or pertuzumab, they are offering free foundation test. Otherwise, it is costing more than 2 lakhs.
Okay.
But, so this should be done for this patient, so that at least something, if it comes out, we can offer to this patient, sir. Because that test is being offered free from the Roche side. If any patient, like, because patient has already progressed on atezolizumab, so that test should be, sir, like done in this patient.
Point well taken. I think it is a value addition that you have provided to us. We'll certainly look into it.
Sir. Thank you, sir.
Thank you so much.